So chemotherapy is the start of video number 2 for cancer and HIV. Um, Anyone undergoing chemotherapy needs a lot of psychosocial support. First of all, they might think they're dying, um, and they have a lot of life decisions to make. Then there are um, just the crazy things that happen with chemotherapy. But let's start with the 3 types of chemotherapy, or the main types, I should say. Primary, 1 or more types of chemo is used, and this is curative. Combination is chemotherapy with radiation. And then palliative. Palliative chemotherapy, you have to understand that it's not going to cure the patient, and it's not intended to cure the patient. It is intended to keep the symptoms down. In other words, shrink the tumor enough that it might relieve some of the pain that the patient might be under. In an ideal system, chemo kills a constant portion of the remaining cancer cells with each dose. Between dose, cell regrowth occurs. When therapy is successful, cell killing is greater than cell growth. And again, healthy cells outlive the unhealthy cells. Chemotherapy classification is antibiotics, alkylating agents, anti-tabolites, vinca-alkaloids, monoclonal antibodies, hormones, and aromatase inhibitors. You don't really need to know all those different things now unless you're going to be a chemotherapy nurse, and you're not going to be a chemotherapy nurse in your first year of practice. Just know there's a lot of different kinds, and they mostly affect the RNA and the DNA of the cell. They can be administered orally, subcutaneously, intramuscularly, IV, arterial, peritoneal, intrathecal, and intracavity. So just about any way you can pour something to poison those cells, they have found a way that they can do it. And then our next group of slides deal with different kinds of medications, and I'm not going to go through them all except for a couple. And the first one I want to bring to your attention are anti-neoplastics. You will see a lot in practice. You'll see tamoxifen and methotrexate, and these can be used for different kinds of cancer, and they have some pretty significant side effects. Numbness, tingling, edema, pain. Patient might lose their grasp. Sometimes they have to adjust the dose. Treatment for if they have pain or, hand-foot kind of syndrome is creams, topical corticosteroids, different vitamins, that kind of thing. Most LPNs are allowed to give methotrexate because it is a oral chemotherapy, but before you give any anti-neoplastic drug, make sure that you check the policies of the facility where you're working. The next kind that we want to talk about is immunotherapy. The main one you're going to see is interferon, and it stimulates T cell production. It's different from a chemotherapy. It stimulates T cell productions that basically try to kill off the bad stuff. They also use interferon. It's used with leukemia, AIDS, Kaposi's sarcoma, and it's also used for melanoma. But remember, melanoma does not have a cure. Interferon, though, can really delay any progression sometimes of melanoma. Side effects. It goes on and on and on what the side effects to chemotherapy are, and it all depends on the patient, how much chemotherapy, what combination, so there's no tried and true. But chemotherapies that deal with cellular reproduction are going to cause alopecia, which is hair loss, sorry. Almost every chemotherapy will cause some sort of nausea, vomiting, GI upset. Some will cause hemopoietic suppression. So this is when you have like red blood cell, white blood cell problems. Patient becomes neutropenic, that kind of thing. Um, Lymphedema, pain, depression, and cognitive changes and sexual dysfunction. So if you look at this slide, and let's look at the next slide too. No, let's just stay on this one. Look at what's going to happen to this patient psychosocially. They lost all their hair. They can't be around people because they might get an infection from them. If they have lymphedema, one of their limbs could be completely swollen and looked malformed. They don't feel well. All of these things, and this one, in my opinion, cause depression. And then cognitive changes, if there's a brain issue involved, we have a really bad problem. So we really have to support this patient. Body image disturbance, all kinds of things to help them. And then we go on to the next one. And there's even more really nice things that we can talk about. Nausea and vomiting. Everybody looks forward to that. Anorexia and early satiety. This means they don't want to eat, and when they do eat, they take about 2 bites and then they're full. Diarrhea, constipation, sore mouth, and thrush. Remember, antibiotics and chemotherapies are not discerning. So they'll kill good cells, they'll kill bad cells. They don't care. So they kill the good bacteria, and the patient can get thrush. And thrush can go all the way from the mouth and out the body. And as we've discussed before, it can be bad enough that things need to be amputated. Patient will lose their sense of taste, or it will change. So sweet things taste sour, and so on and so forth. There are some meds that help, and chemotherapy and the medication regime that precedes it have really come a long way. Reglan deals with gastric emptying, so the patient might be able to eat better. Compazine, Zofran, Phenergan are antiemetics. And make nausea and vomiting worse. Remeron, these kind of drugs can help with agitation. Remeron stimulates the appetite. Benadryl reduces any inflammatory process. So these are just a few of the drugs, along with pre-dosing the patient with steroids before they have chemotherapy. Alopecia might be one of the biggest psychosocial issues involved in cancer, and you kind of think it's silly because, okay, they lost all their hair, but they're still alive. But hair loss is a big deal, especially for women, and it's now kind of become the trademark and almost the sign of strength and bravery for women with breast cancer. They could lose all or part of their hair depending on how thick their hair and strong it is. Not all chemo causes this loss because, like I said, if it has to deal with cellular reproduction, then they'll lose their hair, and if the chemotherapy doesn't work that way, they won't. They can lose the hair on every part of their body. You want to encourage the patient to use very mild shampoo, soft brushes. Hair dryers are dangerous. No coloring or perming the hair because that'll just make it fall out. And then when they're bald, they need to use sunscreen on their head. I have a bald husband, so that's a pretty normal part of our life, but it's not for him, but not for me. So that is a big educational thing, dealing with alopecia. Sometimes when the hair starts to fall out, you might want to encourage the patient to actually shave it because it looks better. It doesn't have that chunks here and chunks there look, or at least cut it short. Help them with wigs or scarves, finding hats. I know that a lot of wigs are uncomfortable because they're tight and they're hot, but they make these really cute little cotton hats. They're made out of t-shirt material. You can teach the patient to wear one of those with a scarf around it, and they're actually really cute. Hard to convince somebody of that when they don't have any hair, but you really want to support them however you can and listen to their feelings. Validate what they're saying because it is very, very difficult. I may have just confused you because I went from slide 55 all the way up to 65. Again, the slides in between, you can read on your own, study the notes that are at the bottom of each one, and that will give you the information that you need. And now I'm skipping to nutrition because chemotherapy, we could go on, you could have whole classes on chemotherapy, how to administer it, which one's going to do what. But what you really need to do is talk to the patient and support the patient. So one thing that really, really important to me when dealing with an oncological patient is nutrition. And as we've known from every illness we've studied, nothing is going to heal if the body isn't properly nourished. And also the chances of cancer are far higher if you're on a poor diet, if you drink too much alcohol. So we really want to talk to our patients. And this is when you're dealing with healthy patients in an office setting, who are there for regular visits, to really watch their nutritional intake. Learn what good fats to eat, learn what vegetables to eat. Again, we've talked about nutrition a lot in different classes, but in oncology, it's so very, very important. Because of the chemotherapy, because of everything that's happened, the patient will suffer from malnutrition in different regards, leading to anorexia, cachexia, which is basically your body starving itself together, starving itself to death. If nutritional support is good, the chemotherapy will work better and the patient will not lose as many healthy cells. So we have to really watch that we are pushing nutritional issues. As you know from previous units, wounds don't heal if there's not significant protein. Fistulas can form because the muscle tissue can break apart. Infections can happen. When someone's malnourished, the survival rate's lower. Their quality of life might be terrible, and they might stay in the hospital longer. None of those things do we want. So let's, protein, healthy carbs, energy, low sugars, lots of fluid, whatever we can do nutritionally for the patient will just help them. The next thing we need to know, and we have to be very careful with the issue of spiritual needs because we always want to put our own spin on things. No matter what religion you happen to profess, you can support the religion of your patient. And you need to support the religion of your patient. So when you're talking to your patient about spiritual issues, you need to understand that their beliefs are paramount, not yours. Talk to them, listen to them, pray with them if they ask you to. Offer to pray with them. I think one of the biggest blessings of my job has been connecting with people at the end of their life and just talking to them, listening to them. They share very intimate things. They share memories. Praying with families is an amazing blessing, and it doesn't matter if they're my faith or another faith. I'm going to support whatever spiritual need they have. If I can't meet it, if it's something that I am not at all familiar with, I will find the right person, someone who practices that faith that can support them in a way that I can't. I'm very transparent. I don't say your religion is wrong, but I might say I don't know anything about your faith beliefs, so you're going to need to educate me so that I can help you. And if you show that interest, patients are not offended by that. They want to help you. And again, we're going to start HIV next, but I'm going to end with this slide on this video, and we'll start from here in the next one. So this is video number 2.